Hello, welcome, and thank you everyone for being part of this Northern Region Health Coordination Centre webinar. I'm Dr Carl Cole, GP and Papakura Health Family Doctors. I'm facilitating tonight's webinar as we reach this critical stage of the COVID-19 vaccination program, with the final push to reach that 90% fully vaccinated target. We're going to let you know the latest on the vaccine program, acknowledging primary care's substantial contribution to this, and how you can contribute to proactively encourage and support vaccination as we take the next steps. We also have some great speakers for you, including Dr Matire Harwood, Papakura Marae Health Clinic, talking about those who are vaccine hesitant in our community and sharing her insights on how to encourage vaccination. Tevita Funaki, CEO of Fono, who will talk about their approach to encouraging COVID-19 vaccination in their Pacific community. Then we have a clinical update from Dr Nikki Turner, who is, I'm sure you all know, the Medical Director of Immunisation Advisory Centre. This will be then followed by some questions and answers session where we will try and answer as many of your questions as we can. We also collocate and provide written answers to those questions. We'll let you know via meetings when these are available. As always, we really appreciate your feedback, and so there's a poll at the end of this webinar, so please fill that in for us. Also, I just want to let you know that this webinar has been recorded and we'll share this with you via email. Now, I'd like to introduce Matt Hanna, from the NRHCC team, who will provide an update on the COVID-19 vaccination program in the Metro Auckland. Matt is the Vaccination Program Director. Matt was Director of Strategy and Transformation in the National Health Service in London, and he has a background in health economics and health policy. Matt. Matt, I think you're muted.
Thanks, Carl. Tēnā koutou katoa, Cormac Hannan Topawingawa, as Carl said, the Program Director. I'm just going to give you a brief overview of where we're at with the vaccination program. I'm just going to pull up some slides here. Slideshow going. So yeah, look, really incredible progress across Metro Auckland when we look at the vaccination rates. When we're expecting Auckland DHB to get to that sort of magical 90% double dosed late this week, actually. But I think we're really just sort of mindful and hugely appreciative of the massive contribution that primary care, GP clinics and pharmacies have made to that. We've got over 208 GP clinics providing vaccination now in 127 pharmacies, which is really incredible, and we've still got people coming on board, which is fantastic to provide those services. We've got really good vaccination rates now for the sort of older people within the population, are really focused on younger people, and you'll hear from some of our colleagues later about some of the incredible work they're doing. Just 10,700 doses, first doses to lift those Māori vaccination rates to 90%. So we're really sort of taking a laser-like focus on that equity work, really supporting our Māori and Pacific partners and providers in the great mahi that they do every day in the community, reaching out with the big events that you see in the small events, working workplaces, working with community groups, going door to door. That's the kind of incredible stuff we're seeing at the moment, and that's what's really seems to be making the difference in lifting those rates. As I mentioned, we've got some really incredible work happening across Auckland. GPs and nurse practitioners have been doing a lot of proactive conversations with their enrolled populations. We've seen a really great result from that. So 37% conversion rate once people have had that conversation, leading to a vaccination after that. So again, that's been really incredible, on top of all the other hard work that goes into lifting those rates. There's lots of other things happening across the board. So we're providing free transportation to and from vaccination centres, in-home services, which are funded, and really sort of focusing on getting as many providers up and running as we can across the board, and pivoting into mobile services where we can. And then primary care has been playing an important role in administering that third extension dose for people who are immunocompromised. You'll hear from colleagues about some of the incredible sort of outreach activity, highly targeted work, so I won't go into too much of that now, but there have been literally hundreds of events completed, and more, at least 100 in the lead up to Christmas, which is really only 5 or 6 weeks away. And you'll have seen the Got Your Dot vaccination event at Eden Park, and then the fantastic event that was at Mount Smart Stadium last weekend, about 3,000 Pacific people going to the Māori Pacific going to that event. There's all the vans and the camper vans out, and I think a lot of opportunities to kororū with people and provide education, build confidence within the community. We've visited over 732 households now. And this is in addition to in-home vaccination provided by GPs and pharmacists. We've done a really significant amount of work with disability organisations, just acknowledging the huge contribution there, and the number of people who've been visited, and specialist educational organisations that have been supportive of that process. And we've been doing a lot of work in the transitional housing, boarding housing and emergency housing space, motels and the like. Very vulnerable community, and a lot of work with specialist NGO organisations and other parts of the community to support people who are experiencing homelessness and such like. And then a lot of work around the comm space, and promotional activity to encourage those doses. I think where we're looking to now, thinking forward, the AstraZeneca vaccination will be available from late November. We are looking at a quite limited rollout of that, just given the targeted nature of that. Obviously, Pfizer is still the primary vaccine for New Zealand, so that will be available through a small number of sites initially, and then we'll look to expand that, just looking at what the uptake is. But that's really focused on people who are either contraindicated for Pfizer, or there's some sort of issue with getting Pfizer and they're under a vaccine order. As recently announced, the booster doses will be available from the 29th of October. Primary care will play a significant role in that, and we'll be doing work through all of our vaccination centres to get that up and running for anyone who's over 18 and over 6 months since their second dose. And we're expecting that people will be able to book for that towards the end of November, and really just working through how we prioritise and take a risk-based approach for that, particularly for healthcare workers and border workers who were vaccinated way back in sort of February and March time. We're also doing a lot of planning work around the rollout for 5 to 11-year-olds, really thinking about how popular primary care has been for the 12 to 15-year-olds. Well over 50% of all doses administered were done through general practice and pharmacy, so thank you for that. And we're anticipating that will be another popular setting for the next group of young people going through there. But we'll also be looking at school-based or school-located outreach services, as well as people being able to go through our large vaccination centres. And then really sort of taking a broader approach to vaccination next year, and thinking about how we integrate with other services. So that shift really continues towards outreach. With the boosters coming on, it's really critical that we're going to remain and maintain that really sharp focus on getting the first and second doses up for everyone in the community. So we'll be preserving and maintaining all of that outreach capacity as we support the booster campaign. It's really about providing a highly flexible model that can really reach into the community and support it in the ways that it needs. Really working very closely with our Māori and Pacific partners. And we will be seeing some changes in our large DHB vaccination capacity as we go through this. So we will be maintaining a few of the bigger sites next year, but we will be closing a few of the others just now that we've got so much other capacity from general practice and pharmacy on board. So really looking at getting that sort of booster campaign wrapped up before the end of the summer, sort of autumn period, working very closely with primary care on that, and really thinking about how we provide a number of vaccines at the same time, particularly flu, and thinking about that period into winter. So there's lots happening right now. Really keen to lift those rates and get the highest possible coverage that we can across the community, getting those boosters underway, and then shifting our focus to next year and thinking about how we support the 5 to 11-year-olds, and then conclude that booster campaign towards the end of autumn. Thank you, Carl. That's it.
Thank you, Matt. Now I'd like to introduce, there she is, I'd like to introduce Dr Matire Harwood from Papakura Marae Health Clinic, who will talk to you about those who are vaccine hesitant in our community and sharing her insights on how to encourage vaccination. Dr Matire Harwood Napuhi, excuse me again, is an associate professor at Auckland Medical School, as well as a GP at Papakura Marae Health Clinic. She's a member of the Ministry of Health COVID TAG and is a member of the COVID-19 vaccine STAG, tasked with recommending the vaccine for Aotearoa. Okay.
Kia ora tātou, just had to find my unmute button, and many thanks for the invitation to come and talk with you this evening. So I'm a GP at Papakura Marae Health Clinic and also an academic at the University of Auckland, and I can see some familiar faces on the chat, so yeah, lovely to see you all tonight. I'll just be talking from a Māori perspective and our experience at Papakura, and I'll be using a rights-based framework in my talk this evening, and it's just to say that, you know, Māori have a right to the best healthcare and the best health outcomes, and for me the Pfizer vaccine is the best that we have available, and so we have a right to access that equitably, and that's the kind of framing I use with the patients as well. And just to understand that, you know, currently we are experiencing very high rates of COVID infection, and particularly in Papakura at the moment, and you may have seen me on the news going out to visit many of our whānau who are isolating at home. So we're almost a third of the current cases as of the weekend. But also there are major inequities in terms of those wider determinants that have influence or impact on people's decision making and in the responsiveness of the health system. So we play a role in terms of meeting the rights of people and accessing evidence-based treatments such as the vaccine. And importantly, these are unfair, but they can be reduced, eliminated and prevented. And so that's key in how I work. Unfortunately, the vax rollout did miss many Māori. Being a younger population, it meant we were off in group 4, so there was a longer time before we were able to access the vaccine. There are major other access issues, and you'll see that now with the rural communities, some of them having to travel an hour or so to get to a vaccine clinic, in addition to working long hours and not being able to come into primary care with some of the vaccine clinics that we have around our community because they're working late. Many are wary of the government and the mandates, of course, and because there was that longer lag period, they've been exposed for a longer time to misinformation. And then, you know, I think we were saying this for a long time to some of our Crown and health systems, but they didn't listen to us when we said that we really need to focus on this early on, get it right from the beginning, because everybody's going to benefit if we get it right for Māori. But importantly, it can be done. So I just want to talk about our experience at Papakura. This was our dashboard around the national health targets, and I know it says 2017, but we weren't able to maintain this for the 2 years afterwards until COVID hit. And you'll see here that, you know, childhood IMS, which everybody says is an issue for some Māori communities, we were able to meet that target, only missing out on one child getting the timely childhood vaccination. So I don't, you know, that's why I continue to do the work that I do, because I know that it can be done and we can get this right for Māori. And some of the lessons that we learned as part of this whole process in our practice was that achieving equity is for us about being excellent, being clinically excellent. We had champions for each of the targets and had a little bit of competition between us, so that we were always checking each other up for each quarter and seeing how we were going. Having good quality data is critical. And I enjoyed Matt's talk and being able to hear some of those numbers so I can understand a little bit better on how I might adjust some of the work that I'm doing. But finally celebrating the work that we do, because it has been tough for us in primary care and it will be tough going through these next 3-6 months. So we need opportunities to celebrate each other in the work that we're doing. And I just also want to speak to another fabulous, more recent example around COVID, and this is Rachel Thompson, who as soon as the COVID vaccine became available, she knew that misinformation may be an issue through social media in her community, and so she hit them very quickly, very hard, and now 80% of them are vaccinated. So again, we know it can be done when there's mighty leadership of it. Big events have had some success. So Super Saturday, we saw 3.8% of Māori were vaccinated on that day. So almost 10,000 Māori got their first vaccine, COVID vaccine dose on Super Saturday, which was awesome. About 4,000 Pacific people and about 40,000 people across Aotearoa. So really good numbers for Māori in that space. We decided to take up the challenge on that day too. So we had 5 or 6 of us sitting at Papakura Marae Health Clinic, ringing 600 whānau from around the community and asking them to come in for the vaccine. 30% answered the phone, and we were able to actually talk through their concerns and anxieties and questions around the side effects, interactions with their medication and health issues. And they came in for the vaccine, which is, I guess, the same as what Matt was showing with the GPs having those critical conversations. 10% of them said they did not want the vaccine at this time, but we kind of expected that. And yet I still feel like I planted some seeds and I've left the door open for them to come back and see me. So I'm hoping that we'll see some shift there. But 60%, we were not able to get anybody out to answer the phone. They were either at work, the phone wasn't working, or they didn't answer, it went straight through to message, or didn't have a phone. And so these are the people that we need to hit and do something differently with, because they're not engaging with the usual types of programs that we offer, and suggesting that one size does not fit all. So we need these other ideas, and Matt talked to this briefly, and we've been pushing for this Kaupapa Māori outreach sort of program. So they've been running it at Manurewa Marae, similarly at Papakura Marae as well, where we do take leaders out into the community. They are Māori doctors, Māori nurses, kaumātua, rangatahi, who are doing well in their communities, getting out and having a kōrero with people in their driveways and their gardens about the vaccine and answering that. And we've had fabulous uptake there. We provide manaaki in terms of the food and things like that to celebrate them having the vaccine. So we don't say incentives, we don't say rewards, we say this is manaaki, this is a chance to celebrate your decision. Kanohi is all about having the different faces. So we have young people, older people, as I said, doctors, community health workers, so that people can see a face that's relevant to them. And we're all about excellence. So we make sure that we're clinically of high standards, as well as a kaupapa Māori standard of care as well. And just some of the feedback, I like the voucher, but it's the people. You can't train that, what's here today. You make me feel good about having the vaccine, thank you. And beautiful, the people, the music, inspiring people here, encouraging you, make you feel valued that you're here, and the workers put all their heart into it. So these have been our weekends over the last couple of months, is getting out and actually doing door knocking and speaking with whānau in their own communities where they feel safe. And it wasn't until we did that we started to actually look at what's the international evidence for improving Indigenous people's vaccination rates. And I came across this paper from India showing that, 100% vaccination rate is possible. And they talked about the lessons from their program, which was similar to what we are doing with this Kaupapa Māori outreach. having a broad and diverse set of local leaders, having simple messages delivered by them. Don't provide or talk about incentives, it is about celebration. Focus on the convenience, so having it in their communities on days when they may not be working or after hours, and making sure that you're collecting data and always improving what you're doing so that you know that you can only get better. And that's the end of my talk. Ora mai.
Oh, thank you, Matthew. That was really interesting and yeah, very encouraging from a personal point of view. I know I've had similar challenges of all of my COVID positive patients so far in Papakura have been Māori. We'd like to move now to our next speaker, Tevita Funaki, who's CEO of the Fono, talking about their approach to encouraging COVID-19 vaccination in the Pacific community. The Fono provides primary health, social and education services across Auckland. Tevita is a Pacific Health Manager at ProCare Health before becoming CEO of the Fono, and has a background in finance and health management.
Kia ora tātou whānau. Manuelele and warm greetings. Thank you for the opportunity to share our journey as a response for Pacific, from our Pacific community, led by a lot of our Pacific providers here in Auckland. I'll be sharing today a perspective from the Fono, but similarly to a lot of our other Pacific providers, very similar initiative that has been drives through those organizations. Firstly, when we started the vaccination drive, we set up 2 Pacific localities, Vaccination Centre at Otara led by South Seas and the one at Westgate. We knew that we had to create a place that it feels like a Pacific home, that has the warmth, that has the Pacific people that are driving it, and make people, Pacific people coming through and have good experience. And through the Westgate drive, we've done over 32,000 of vaccinations in there. During this Delta, just under 30,000. So it was not only just vaccination, it was about people's good experience, creating a place like a village and a home for them when they come through to get vaccinated. We also targeted through here in terms of families and driving families to come together as family and get vaccinated. We pivot during this Delta in terms of our approach through the different drive-through and also the pop-ups clinics, and we utilize both the bus, some initiative we set up the cold chains there, some initiative we just, depending on the size, we sent through the camper vans into this initiative. We targeted ethnic specific, whether the Fijians or the Kiribati, the Tokelauans and the Tuvaluans, Niueans in each of the various Pacific ethnic, and utilize their leaders to actually drive it and mobilize their communities to come in and get vaccinated. Again, each of these sites create and feel like a kolo or village. The music, the staffing that we're delivering, the services in there was from the Pacific ethnic group, Tongan for Tongan, Samoans, and we found that there was actually worked really well. And building into that, it's about who are the leadership within our community that we partner with to try and mobilize families to come and get vaccinated. When we kickstart, we started off with the Malui Matonga, or targeting the first drive-through ethnic group with the village. It was critical that we knew as an organization and also being part of the Pacific Collective that we needed to do this well. There'll be a whole lot of learnings from this. And again, as I touched on, it was creating a village that it feels Tongan. The locality, the locations was actually important. The workforce, Tongan workforce or community was coming in there because they feel that our own Tongan workforce are actually delivering this. So this MMT drive-through became a model that was utilized for other organizations that we partner with or their own initiative targeting ethnic. So during just the drive-through, just from see the success, and again, I think mentioning there that continue improving in terms of the approach, whether it was actually the VAC Centre or at the drive-through, as a collective of providers, we continue to look at what can we do better going forward. We also had some of Pacific GPs that were practices that were vaccinating, and including Beta Drive or Tongan Health Society. So while some of our organizations was actually delivering, setting up the locality, some were pivoting to focus on being vaccinated in clinic themselves. But part of the initiative is in here is driving access to our Pacific families, whether they come to our initiative or come to our GP clinics, but also getting access to other supervics or pharmacies or other drive-through. Doesn't matter where they actually get access, was all about how can we motivate them to and their families to get vaccinated. A touch on community engagement that was hugely important was actually utilizing our leaders, our church leaders, our community leaders to drive the messaging, to drive the mobilizations into their own group. We also utilize a lot of our youth, and not more now in terms of getting to the hard to reach, is really utilizing our young people to actually drive each of the events. Statistically, young population, still large majority of our unvaxxed actually are young people. So our young people are actually taking the lead. Most of us actually preparing the site and from the back supporting our youth leading it. So very quickly, in terms of the community approach, it was actually working really well in terms of our engagement. So the leadership was important. That both a different level of community, our Pacific church and community leaders, our youth leaders. We targeted parents and grandparents, and also key influence, whether they're sport, academic. So the Pacific celebrities was utilized to also push the messages through. Culturally appropriate, ethnic specific, and also Pan Pacific. When we touch on Pan Pacific, our youth are more Pan Pacific events, whereas targeting our middle-aged and also older people through the ethnic specific. Language was important, so having Pacific staff at this initiative tries to relying on the trusted relationship and network. Touch on Pacific workforce, working through in terms of being targeted and where we actually go with its heat map or actually the data from against RCC, the DHP, and using those insights to drive where we position ourselves. The locations was important. A location that was actually familiar with each of the community is where we actually pivot to. And the approach where they come through is for vaccinations, we engage in a much more holistic approach and support for the families. Digital is we actually pivot to the digital, so ensuring that we have all means, whether social media campaigned or through ensuring that the right message are getting to the homes, whether social medias or utilizing our ethnic-based radio stations, or even just phone conversations from home. What we're working through now is actually managing COVID in the community. So collectively, as a group, is working through the setting that up for the design and development. Next phase is actually moving much closer to the homes, taking it into the vaccinations targeted into the homes. There will be still continued pop-ups, but will be targeted pop-ups, and a lot will be driven through by our youth to engage our younger people through vaccinations. Secondly is, how do we partner better with some of the other organizations, whether they're GP clinics or other NGOs, to provide a much more holistic support to our families. In the end, every door and every service that we deliver, vaccinations is a conversation in there. Thank you.
Beautiful slide there. And thank you for those insights, Tevita. I certainly agree, and I just wholeheartedly, the essence of general practice is us being in the community and part of it and a familiar face. Our next speaker is Dr. Nikki Turner, Director of Immunisation Advisory Centre. She's going to provide a clinical update. Nikki's an academic GP. She's an honorary professor of the Department of General Practice and Primary Care and medical director of IMAC, the Immunisation Advisory Centre. She's developed and evolved IMAC from its inception in 1996 to a national communication coordination and education research centre. She's on a range of national committees supporting the New Zealand Immunisation Programme and COVID vaccination delivery. Over to you, Nikki.
Kia ora all. Thanks, Carl. That was a long introduction. Thanks so much. So I'm just going to briefly go through for us some of the key clinical issues that are coming up. Many of you may already know them, but these are the recent ones that we've been really thrown with in the last couple of weeks. So I'm just going to talk about the third primary dose for immunocompromised, talk a bit about vaccine exemptions, and then talk about the AstraZeneca boosters, and then touch on vaccination for 5 to 11-year-olds. And hopefully, really, it might be more useful just to have some Q's and A's time to see what other questions people have got. So the first one is that, as you're all aware, that now the ministry has recommended a third primary dose, not for any immunocompromised, but for severely immunocompromised. Now, the problem is this is not your classic list of people who the flu vaccine is targeted for, who are medium or moderate or mildly immunocompromised. This is really for the severe end of immunocompromise. Now, the problem with this is that it hasn't got MedSafe approval because, of course, this is a very small group. So there's not a lot of data on the safety of the third dose. Now, I don't think any of us are concerned. We're pretty confident that this is a group of people that may benefit from a third primary dose. But because it doesn't have MedSafe approval, that's why we're in this difficult position that it needs a medical practitioner prescription. So people turn up, we need to write a script and do a consent form and then send it to the vaccinator. So that's the first problem, is just a technical problem for us as GPs or nurse practitioners. The second problem is that it's really hard to easily identify this group of our practice management systems. So my way of thinking about it at the moment, there are a few groups out there who are trying to do searches on the PMS and trying to figure out some search terms. But if you haven't got some clever search term approach, then I just suggest just think of all of anybody that you can think of clinically who might be significantly immunocompromised. Now, there's a huge list, but they're quite rare in any one general practice. The thing I'd like to highlight is that clinicians are allowed to use their judgment for conditions or medications that are not listed here that are associated with severe immunocompromise. That basically, if you see somebody who you think is likely to be severely immunocompromised, whether they do or don't fit this enormous group, we've got discretion to offer them a third dose. Now, this is a huge group, but I just note that the ones that are highlighted in yellow there are ones that have recently been added that weren't in the first list. And particularly, I noticed that they've now added in long-term hemodialysis or peritoneal dialysis, which had got left off the first time. So this group is too large for my headspace or for anyone else's. Just think, have I got patients who might be immunocompromised? Do they fit in this list? Or if I'm still worried about them, we're entitled to offer them a third dose. Now, just to clarify, this is a third primary dose. Once these people have had their 3 doses, they're still entitled to a booster and should get a booster 6 months later. So the intention of this third dose is just in case they didn't respond well to the first or second dose, because many of these people would not have done so. And the other thing is, if at all possible, and it's often not, if we can time the giving of the vaccine when they're least likely to be immunocompromised. So if they're going to come off a medication or a reason for being immunocompromised and you're able to have a 2-week gap before you vaccinate, that would be ideal. But obviously it's often not the case. So the next somewhat problematic issue for us as GPs is vaccine exemptions. And I'm sure everyone's been in the position recently of being asked about vaccine exemptions and who would fit the legal definition of vaccine exemptions. Now, the important thing is we don't have to make the final decision. We just have to look down this criteria and think, could this person possibly fit into a vaccine exemption? Have I got any evidence for it? And if which so, we fill out a form and submit it to the Ministry of Health. They've developed their own committee to look at and make the decision around vaccine exemption. So that takes the heat off us as frontline general practitioners. We just look and think, could this person fit in the list? Now, as we're all aware, the Ministry of Health is keen to keep this to a very small list. and most of it is very small. So you can see that somebody who's got PCR confirmed infection is exempt until they're well from the infection. We don't recommend vaccinating anyway till a month after you've had infection. So that fits with that. I think this 1B group is the one that many people will be thinking about whether they can fit into. So this 1B group is where somebody may have had a serious event which is attributed to a previous dose of the COVID vaccine when there is no other cause identified. So there are some, unusual events that we're not sure where they came from, whether they could have been vaccine related. If they end up in hospitalization or prolongation of existing hospitalization or persistent or significant disability, incapacity, then they could be considered for an exemption. Now, this is the group where people that may have had an exacerbation of their chronic fatigue, maybe regional pain, maybe severe POTS. And some of these conditions, we're not sure where they come from. Many of them may have been immunization stress-related events, but some of them can be very severe and persistent. They may be eligible for a vaccine exemption. So moving further on the vaccine exemptions, you can see, go back to there, I think in this case, as a qualified general practitioner, we are a relevant medical specialist in our own areas, but if you want extra support, some people may well get neurological or cardiovascular review about their conditions, particularly if it's persistent. I think to help us, it's a good idea to get a secondary review. If you're concerned or you're not sure, you can certainly ring our IMAC phone line and see what advice we may be able to give as well. Now, some of the examples that we've hit are people that might have had severe ITP, obviously myocarditis, but particularly the ones around severe CFS and myalgic encephalitis are the ones that are most challenging. I think the other criterions are more obvious. Somebody who's had a neurodevelopmental condition that may have been unable to tolerate in vaccine administration, that's incredibly rare, and I think most of us are finding ways around that. Anaphylaxis to the first dose of the vaccine, very few, and our immunology colleagues have actually been able to vaccinate a few of these safely. But of course, with the arrival now of the AstraZeneca vaccine, that criterion is not likely to last. We have a few people in the country who have had myocarditis or pericarditis from the first dose of the vaccine. These people we would be offering the AstraZeneca vaccine to, not a second Pfizer. And then you've got these severe inflammatory cardiac conditions, which are pretty rare. And then a very small group of people in Auckland who are actually part of a trial at the moment undergoing, and so still on the trial till that's unblinded. So that's the list. That's the exemption application form. You can get it off the Ministry of Health website. I think it's on Clinical Pathways now. So that's what we fill in if we think we've got somebody that might fit a criterion. And then it's up to the Ministry of Health to decide. We're not quite sure how rapidly the Ministry of Health could make the decision. We understand that they have dealt with a few exemptions over the weekend, but it might not necessarily come back rapidly. So we don't have a lot of control over how the ministry is going to manage it at their end. So happy to take more comments or questions on exemptions, but I'm just going to rapidly move on to boosters. So as you're all aware, the government has made the announcement that we will be able to offer boosters to everybody 6 months after your completion of the primary course. So that'll be after the second dose, 6 months later, or if you had a 3-dose course, 6 months after that. Now, I just want to highlight there's been a lot of concern and angst about boosters, but for New Zealand as a whole, still, the major priority is getting the first and second doses into people, and particularly young people. There's no urgency for boosters. I think immunity stays strong for a long time. What we're seeing from the clinical data is you're getting antibody waning, particularly in the very elderly, from about 3 or 4 months. And you're starting particularly to see the antibody waning from 6 months onwards. But it's not like we lose our protection at 6 months. We've still got quite a lot of protection from 6 to 9 months. So from those of us who are well past 6 months now, it'll be great to get a booster, but I don't think we need to feel too concerned that we've held off too long. The other point to note is the boosters is for 18 years and older, because that's the licensure data that's presented to MedSafe. It was from 18 years and up. But there really is no need at this point to give boosters to people under 18 years. they've got vigorous immune systems and they would have responded well to the primary course. So the priority groups are us, frontline healthcare providers, the elderly, Māori and Pacifica from 50, and those with the comorbidities. Now, those are the groups that were rolled out first anyway. So I think there's a natural order to boosters that will follow through the natural order of how we've been giving the vaccines anyway. Now, just to reassure us all that we still actually have some protection on board and we're not all suddenly going to get COVID before we can get our booster within the next few weeks. I just want to highlight this, that this is showing data. At the top, it's data just from symptomatic disease, and at the bottom, it's hospitalization. Now, that's the AstraZeneca vaccine, and you can see that there is a drop-off, a pretty significant drop-off by 20 weeks. Now, the Pfizer vaccine, our vaccine, you can see that there is a drop-off, but not to the same degree. That's the Moderna vaccine, the other RNA vaccine, which is holding up really well. Now, what you can see when you look at hospitalization is there is a drop-off for the AstraZeneca, but hospitalization for the Pfizer dose 20 weeks out, this is English data, is still strong. So it's great we're getting a booster. I recommend it for everybody, but I also don't think we need to feel anxious that we haven't got it earlier, because it's certainly holding up well to date. Now, just touching briefly on the AstraZeneca vaccine, we're expecting it in the next couple of weeks. It is a vector vaccine. It's a different sort of vaccine. It's actually the most widely used vaccine in the world. You guys will be aware that some countries are not recommending it for younger people because of the rare association with what's called TCS, which is a thrombosis thrombocytopenia type response, which is seen mostly following the first dose, somewhat more common in young people. You can see from the data I've chucked in here, it's about 15 to 20 per million, higher in younger people and lower in older people. It's got a high case fatality rate, so even though it's rare, you wouldn't want to have it. So that's the most important thing to be aware of in terms of rare severe side effects from AstraZeneca. It is also rarely associated with ITP. And interestingly, unlike the Pfizer vaccine, it is in rare cases associated with Guillain-Barré. And there's approximately an extra 3.8 per million cases of Guillain-Barré over the background rate. So we don't see that with RNA vaccines, but you do see it with this vector vaccine. And it's associated with a very rare thing called capillary leak syndrome. I don't even know what that looks like, but it's incredibly rare. Not recommended in pregnancy at this stage, and it is licensed for people 18 years and up. So who are we going to be offering it to? Well, those with a medical contraindication to Pfizer and those with a personal preference. We'll have enough doses in the country, I'm sure, for it to be offered to those who have a personal preference to use it. If it's used as a primary course, it's got MedSafe approval. It doesn't require a prescription. But the quirk for us is if it comes as a mixed course, somebody's been given a Pfizer and is now going to be followed with an AstraZeneca vaccine, then it's likely to need an approval, a prescription, and a consent form from a medical practitioner or a nurse practitioner. That's the quirk of licensure, that it's licensed for a primary course by MedSafe, but it's not licensed for a mixed course with Pfizer. Now, the clinical data, we've got no concerns about using a mixed Pfizer-AstraZeneca course, and neither have we got any concerns about which of these two vaccines you use for a booster. So I think the Pfizer is looking the strongest in terms of its action, but if people prefer an AstraZeneca for a booster, it's still looking pretty effective. And then I think it was mentioned at the start that each DHB is going to select a few clinics for this to be offered in. I think we're going to have 100,000 doses and they come in 10-dose vials. So quite a lot for a small amount of group of people who are going to use it. I suspect it's not going to be used widely, but we do know there's a few people out there that don't want an RNA vaccine and are happy to accept the vector vaccine. So it'd be great to have that available for them. The last thing I wanted to touch on briefly was whether we will be offering vaccinations for 5 to 11-year-olds. Most of you will be aware that it has now been licensed in the States, and already within the last 2 weeks, the last few weeks, they've actually used large amounts of doses in the States. Now, I think that's useful for us because the clinical trial is pretty small numbers. And even though it looked great in the clinical trial data, you're only talking about a few thousand kids. And so I'm pretty keen that over the next few weeks, the data is accumulating so fast in the States that we will actually have some real world effectiveness data and some real world safety data. So I think that will reassure us about the safety profile. This vaccine is slightly different from the adult. It's a smaller dose. It's got about half the amount of RNA in it. And it's also mixed with a different buffer. So it's interestingly actually slightly more fridge stable. It'll last longer in the fridges. So the company doesn't recommend we just use 1/3 of the adult dose, which is what we thought we could use first. They recommend we use these kid vials. So we're waiting. The data has been presented to MedSafe. It's going through the approval process. We hope to hear before the end of the year with MedSafe process. If MedSafe approves it, there's pros and cons as to whether we should vaccinate 5 to 11-year-olds. The pros are obviously that we get better coverage across the community. We reduce community transmission, which is a significant pro. The cons are still, of course, there's limited data on this age group. And also on the whole, COVID is a mild disease for 5 to 11-year-olds. On the other side, because New Zealand has never had, well, has had very little COVID in the community, the vast majority of our 5 to 11-year-olds have no immunity at all. So even though it's a relatively mild disease, if you let it rip raw through most of our kids, you'll still see some kids just out of a numbers game that get severe disease. So the decision's not yet been made, but readiness and planning is well underway, because I think if there's a decision to rock with it, it'll be rolled out in the first quarter of next year quite fast. That's the end of my talk. I think it's probably more useful to go to some Q's and A's now. There's some questions if you want them. Sorry, there's some ways of finding the IMAC resources if they're useful to you folks. And thanks for giving me the time to talk, and I'll just get rid of the sharing now. Kia ora.
Thank you, Nikki. That was really informative. I mean, I know IMAC is on my speed dial on my web browser pretty much. We are now going to move to the question and answer sessions that you spoke of. Just as a reminder, these are question and answer sessions we're using as the inbuilt one that's inside Zoom. I see a few people with questions already. Please get those questions in there. We're going to have Dr. Sarah Harwood and Leanne Curtin from the NRHCC team are going to help join us answer your questions along with the rest of the panelists. Sarah is an urgent care physician who's been seconded to the NRHCC as a clinical operations lead for the vaccination program. Leanne Curtin is the primary care program lead for the COVID-19 vaccination program. So we'll just look at these questions, and we think we should start with the first one, shall we? So got a few questions there. Please put them in there, or I'll start asking questions. First one is to anyone panel, should we do, is there any data on the optimum time for a booster vax or the waning data?
Yeah, look, there's no clear answer to that. The traditional booster vax is multiple months after your primary course, anywhere traditionally from 4 months. The waning immunity data depends on your age and your immune system. If you're of slightly more mature years like me, your waning immunity is from 4 to 6 months onwards. Younger people, there's really no clear data on waning immunity even from 6 months. So there's not a single answer to that, but the 6 months was chosen, particularly from the Israeli data, as a reasonable time when you start seeing antibodies dropping off. So I think 6 months is a good time. And the suggestion at the moment really is this vaccine is looking like what we call a 2+1. So a primary course of 2 plus a booster of 1. That might be enough for many people for quite a few years. So it's not like we're going to have to keep doing boosters all the time. I'm guessing that we may have to boost particularly elderly people, possibly every year, but not all of us. It might be 2+1 acts very well for quite a few years. And you're certainly seeing a really good immune response to the booster dose, higher than the second dose. So, boosters is looking great for most of us, and don't assume we have to keep boosting. We just have to wait and see after that.
Okay, that's great, Nikki. Can I do a follow-up question personally too? I remember needing 2 extra boosters to get my hepatitis B serology up, and of course that brings the serology question up. Do you see a time where we might try and judge immunity by a serology test, IgM, IgGs?
Yeah, so serology is really difficult because, it can work in controlled situations, but we can't easily start doing serology on everybody. So there's always the question about why does some individual act differently and why Carl acted differently to his Hep B than other people. So we know there's individual variability. I think serology has a small place an individual clinician's decision, but when you're making population decisions about how you boost, I think serology is not like to have a big place. Because the other thing is you're seeing really good cellular memory boost here, which is what you can't measure that easily in the clinical experience. So dropping off of your antibodies doesn't necessarily mean you've got no memory. You've still got good cellular memory. So that's why blood tests aren't necessarily that useful in an individual case, unless you've got somebody who you're particularly highly concerned about.
Yes, thank you. Next question we've got is the third booster dose is Novavax and or the same different mechanism of the Pfizer vax?
Yeah, so there's really interesting stuff out there on social media that people have decided Novavax is the best thing since sliced cheese. So, you know, Novavax is looking good in its clinical trials. It's a traditional protein vaccine that it's got a modern adjuvant in it. So it's a different style of vaccine. It's finishing its clinical trials and looking good, but it's got no rollout experience at all at this stage. I think, and it's got into some people's head that Novavax is going to work better. There were some primary principles that it might be more effective against sterilizing antibodies. So it might be more effective against reduction in asymptomatic and mild spread. But there's no evidence for that. It hasn't actually been used out there anywhere yet because it's not yet licensed in the world. So there is no answer to how effective Novavax is going to be. It's a vaccine that's looking good, but it has yet not been licensed, and it's still a little way off being licensed. So we may in the future have Novavax in our armament as a possible other vaccine. But at this stage, there's not enough data to say whether it would act as good, better, or worse than Pfizer, or whether it can act as a booster. There's no data on the use of Novavax as a booster. I think that was some strange social media thing that ran around the media a month or two back.
Yes, I think we'll look back in this era and just be fascinated at how much fake websites, fake research sites. I've certainly followed some references and found out that they were set up by the whole website and the whole institution, and the research paper was all being backed by certain companies that were banned from Facebook as anti-vax. So it's an amazing time. From Liz asking it, who completes the NRH vaccine exemption form for the patient?
Yeah, so the form I showed online is the form we complete as the frontline healthcare provider, and we submit that by traditional email to the Ministry of Health, along with any other supporting data we've got. Yeah, exactly. So it doesn't get live, sorry. Pathways or anything. It's an email submission to the Ministry of Health. They've got their email on the bottom of it. It's the only way we can submit it, and with any other supporting data you've got, and then it's completely up to the ministry to make the decision after that, and then they will send out an exemption form if they agree to it, or I presume they'll let us know if they decline it. That just makes my IT DNA a bit frustrating. So I might look into that actually. I think that's just, oh gosh. Okay, who in the panel will go? Is the clotting disorder such as factor, got a question, this actually, is the clotting disorder such as factor 5 or cardiac antiphospholipid, those other clotting disorders preclude the use of AstraZeneca vaccine or any vaccine really? That's yeah, no, really cool questions, eh? So my understanding of it is that the clotting disorder is quite different and goes through a different pathway from things like factor 5 laden or antiphospholipid. So my understanding is no, it doesn't necessarily preclude it. But quite frankly, if I had conditions like that, I'd be going for the Pfizer. On the whole, all honesty, the Pfizer's acting like a better vaccine. So people are welcome to AstraZeneca if they're uncomfortable with Pfizer. But I don't see a big use for it myself. You saw my early data about waning immunity and how the AZ's dropping off before Pfizer. I mean, I don't want to thump on AZ. I mean, it's got a role and a place to play, but, you know, I think we're in a really good position with Pfizer. Okay. I'll just ask a question for the rest of the panelists. This is directed straight to Dr. Harwood. How do practices get access to the outreach resources like the mobile vans that are going out to the patients' homes?
Yeah, so that's probably actually more a question for Matt.
The resources guy.
Yeah. Did you want to answer that, Matt?
Yeah, kia ora, can do. Yeah, so there's a couple of options. You can contact our customer experience team, and they will, if you need to book someone a visit, we can sort that out. We've got an outreach team who helps coordinate all this, and we'll share the details after this after this session. I think if a provider has a requirement for a vehicle, we're absolutely happy to look at that. If they've got a big volume of work that they need to do, we're particularly focused on the equity side of the campaign at the moment. So I think you've got three options there. You can either kind of call a mobile team, we can coordinate something through the outreach team, or we can look at providing support if a provider's got a big need.
And we also do a bit of a recce, I guess you'd call it, in the neighbourhoods that we're going to on the weekends. We do a pamphlet drop. So we let the community know that we're coming and what day and time we're going to be there. So when we roll on up, we normally have 50 whānau there waiting for their ice creams and jabs.
Tevita, do you have any suggestions around that?
Yeah, it's normally it comes to each of the providers. Normally, most of the Pacific providers has a mobile service now, and it's just a matter of booking through, or we'll get it through as a referral from Med's team, and some of the families are coming directly to us or neighbouring. We also have some of the working through with the current PHS to actually send through some of the referrals if they're closer to us.
Am I allowed to ask a question of Funaki? Is that all right?
Go ahead.
No.
Sure.
So, as you've probably seen, we've got more people now with COVID in our community. Vaccinating them, I know the Ministry of Health says 4 weeks, but I'm just wondering, there's some evidence that 2 weeks is okay. Some evidence saying do it when you, like I'm doing home visits the day, 2 days after they've got the positive swab. Any thoughts from you? Because I just think that's a potential equity issue in terms of vaccinating them for the long term.
Yeah, this is a really tricky one, Matire, because there's really very little data on the safety of a vaccine soon after the COVID. So, and I think once again, we're just worried about young guys and myocarditis. So probably older people, it's probably fine, but we're outside a licensure again, so that's a bit tricky, so it's on our shoulders. I'd worry about young guys with the high antibody levels, even though they're well after COVID. So I think that's why we recommended the 4 weeks. Now, that also runs into trouble with vaccine certificates, of course, as well. And the other thing is we feel with young people, I know there's a recommendation to do 2 doses after COVID, but we think a young person that's had COVID in a single dose, would be fine and well protected. But unfortunately, we're now up against these legal issues that have said that's not considered legal. So I'm not helping your case here. I'm in a bit of a dilemma about it clinically, that, we don't want to overdose young guys. This is a highly effective vaccine and young people get really strong antibody responses. So I'm just a bit concerned that we have to be slightly careful about that side of it.
Yeah, I got follow on that question. I did a house visit, a family of 8. They were in isolation 2 weeks ago. It was actually 3. It was in the Super Saturday, one of the first ones to be isolated. And these 6 kids from 9 months to 16 years old, and mum and dad, and only 6 of them, 2 of them didn't have positive, and either it was missed and they repeated and they're still negative. So would you vaccinate the 2 who were possibly missed PCR or 2 negative tests with PCR? Should they be vaccinated, but they just not get it? They've got a mucous membrane that bounces the virus off or something, or did they get it? And we assume and they should get a booster at the 4 weeks. And mum was asking me questions like this, and I'm going, I don't know. They were very asymptomatic as well. Only dad got a bit of a headache.
I don't know the answer to that at all. I mean, one could argue that if they're completely asymptomatic, then maybe they didn't get COVID. I mean, were they PCR tested?
Yes. Oh, they asked me to do it. They didn't trust the authorities. So there's my house visit.
Well, assuming you reamed out their brain really well and they were PCR negative, then I would rock with that and say these guys are PCR negative, vaccinate. At least give 1 dose. I'm always cautious with young people about having the second dose too close together after the first. But we're now hitting the dilemma that these guys want vaccine passports. But I'd certainly go ahead with the first dose. I'm just always a bit more cautious then about shoving in a second too soon.
I'd like to add a plea to vaccinate the close contacts. So if you know that they don't have symptoms and if they've had a negative swab, then we'd love you to be vaccinating the close contacts.
Okay, thank you. Next question we have is, could you please advise us on some written info about Novavax, as this is the vaccine patients are holding out for?
Yeah, probably Mr. Google is as good as anyone. Look, but after that question, thanks. What I'll do is I'll go back and ask our guys to put something on the IMAC website for you, because it's coming up time and time again. But the thing you need to say to people is it's looking like a good vaccine. It's a traditional protein vaccine, but it has a strong adjuvant in it, which is a modern adjuvant, so not like traditional aluminium. So it's likely to work very well, but it as yet has no experience outside of clinical trials. We may see it in New Zealand next year, but there's no sign of it yet, so don't hold out for it. But having seen that question, I will ask our team if they can put a little bit more scientific data up on our website, because I know we get asked about it a lot.
Thank you. Look at time, but I think we've got time for the last question, because it's open up to the whole panel. It's a doozy, because it's kind of it's out there, isn't it? It's how do we deal with the stigma of being COVID positive? Who shall I open up first? Volunteers?
I might start, but I'm just going to take the easy part and say it is a bit like breaking bad news. If you're the one to tell the person that actually their swab has come back positive, I'm using that spikes now to break the bad news to them, and then giving them some time to get over the shock. And then we do a home visit, or straight in that next day or so, to show them that it's okay. It's not. We're here to help. We're not stigmatizing you. It's going to be okay. But these are the things that you need to do to keep yourself and the rest of your whānau safe and the community safe from now on. And then just saying, I also say, then in 4 weeks' time, after you've recovered, you're going to get your booster and you're going to be super COVID protected. It's awesome. So trying to give them things to look forward to, I guess.
Good point. I actually had a look up, tried to get some old background when I did nuclear biological chemical training in the army years ago when Afghanistan happened, and I looked at some data and I found the fact of what's fascinating to give patients these 6,000 known viruses that affect the human body. And this is just another one. I've never met a virus I like, but this is it's not a special virus in some ways, but the fact we're not immune is one thing, but it's a virus like all these others. So it's to try and take away, which of the other 6,000 have you got? Yeah. Anyone else got a comment about that?
Because normally when we have a positive case that comes through, we elevate it to an engagement by one of the docs, and the specific, trying to find the right specific person. And then it's about engagement early. It's the one that's positive, but also to deal with the whole whānau, the house, as a household approach or whānau approach. And then the support, then the quicker we engage with them, the better.
Yeah. I guess it's also, I found it's important because it's not as obvious as some people think that positive for the virus or even positive for the DNA doesn't mean you're going to have the illness. It's a correlation between having just the DNA doesn't mean you're going to even have any symptoms. So that's quite a thing I've had come back to me. But I can't have it because I'm not sick, from quite a few people. Last chance. If I know we're 5 minutes late, but it's attempting one last question. I think Nikki will quickly be able to answer this. Will the PED COVID vaccine be given at GP or vaccination centres? The orange PED vaccine with 10 vials, giving 10 kids in the same day can be difficult for small clinics.
Yeah, I agree. Look, that hasn't been answered yet. Remembering lots of general practices still aren't giving COVID vaccine. So they're really particularly focused on around schools and school hubs. And even if they get going in the holidays, there's a lot of discussion around getting vaccination sites around schools and getting the whole whānau to get vaccinated, so all the kids. And then I'm pretty sure they'll be planning school-based programs next year. So whether general practice will play a big role or a small role, we don't know yet. But if we remember back to meningococcal B, that was pretty well all run through schools, and it was actually really effectively run. So we may not have that bigger role to play in this 5 to 12-year-old age group. And yeah, the 12 dose vials is a pain, because that's the other thing. Lots of us wouldn't have that many kids. So I don't think necessarily we should rush and put our hands up in general practice at this stage. I mean, wait till the under 5s, then we're certainly going to have a part in that one, because that's a tricky age group, and that'll be coming eventually too, not too far away.
Yes, and hopefully they get better at the dosing vials and technology around that. I'm looking at the time, and maybe we could take these last questions. If everyone's willing to wait one more minute, or we put these in written questions. So lastly, two last ones, and we'll close it there. Will children's vaccines be available before the start of the school next year? I think, Nikki, you were answering that.
Yeah, it's predicated on those decisions around MedSafe approving it. If you assume MedSafe approves it, the TAG decides we should go with it, then my understanding from the pharma company is we'll be rolling it out in first quarter next year. So yeah, I would have thought so.
Okay, and this is a pretty good one to finish off with, because it's important that we're clear on this. After having COVID, how many doses of Pfizer is recommended? Do they need booster as well after that 4 weeks? Was that 4 weeks the booster, Nikki?
So after you've had your primary course of 2 Pfizer and then a booster 6 months later, I think that's the question, is it?
No, sorry, the question is after having COVID.
Sorry,
COVID is the primary, and then the 4 week is that booster.
Now this is my dilemma. The recommendation is 2 doses, and to get your vaccine certificate, you need 2 doses. Now, personally, clinically, an older person, 2 doses, great, but a younger person, I would prefer only a single dose. That was my comment with Matire before. So for a vaccine certificate, you do need 2 doses. Now, a few of us are still arguing that's overkill and 1 dose should be enough. This is the dilemma at the moment between the legal advice versus clinically. I think we're overdoing it for younger people. So I've not helped you with that one at all.
But at least you would wait, you would probably go the 6 weeks.
That's right, at least make it at least 6 weeks to the second dose. Don't rush in at 3 weeks to the second dose. Exactly. Just remembering that younger people get really high antibody levels, and we don't want to keep boosting them at the height of their
antibody. And if you wait the 6 weeks, Nikki, you're saying that's it, no booster? So it's the COVID.
Oh, so then you've had your 2 doses, okay, and you've had COVID, and you're a young person. There is no rush to boost at all. There's no mandate that's included boosters. So for a younger person that's had COVID and 2 doses, I'd say, don't worry about it. You're all right for the time being. And let's wait and reconsider that in a few months' time.
Yeah, and if they're a health worker and things getting that and a vaccine certificate versus the risk, this is when I'm bringing up IMAC. Okay, hello.
We have asked not to add boosters into the mandatory requirements. Now, that may or may not be heard, but at this stage, we've requested that the mandatory requirements don't include boosters. And this is one of the reasons why we think they shouldn't.
Okay, watch this space, eh? Thank you very much. Well, on that, we are over time. I'm sure people got dinner calling. So thank you, everyone, and all the panelists for tonight. It's been very informative. I wish to thank our speakers and the audience for being part of this. Isn't webinars great? I remember discussing intently with some GPs 10 years ago, getting content this way will be the future, and refusing, no way, I'm never going to do it. But look at this, it's fantastic. So very valuable, and I found it very interesting. So thank you very much, and hope you all found it helpful too. Last reminder, normal thing, please complete the poll as you leave. It really helps with our feedback to keep improving these. Thank you and good night.